We've seen an explosion of new therapies in CLL over the last 10 to 15 years. We started with ibrutinib as a first-generation BTK inhibitor. We now have quite mature randomized trial data for our second-generation inhibitors, acalabrutinib and zanubrutinib, which have clearly become standard of care. And now we're getting even non-covalent inhibitors as next-line options, including pirtobrutinib. In the investigational realm, the BTK degraders are becoming quite of interest, and these are drugs that potentially target BTK for degradation within the cell using the ubiquitin pathway. And so they can work against any potential resistance mutations in theory. And we heard the first bit of data on that at last ASH, but we're awaiting a lot more exciting data in that regard. And then BCL2 inhibitors, we only have one approved drug, venetoclax, but at ASH this past year we heard about a couple of others, lisafdaclax, and then also the BeiGene BCL2 inhibitor, which interestingly also has activity against the primary BCL2 resistance mutation, G101V. And so that's particularly exciting as a potential next generation inhibitor or an inhibitor that will block the development of that mutation. And then, of course, what we're hearing in our clinical studies is combinations of all of these drugs and time-limited therapy so that we can hopefully get deep remissions for patients, stop therapy, and avoid the development of resistance.